So yeah, I'm Emily Earl-Royal. I'm a third, almost fourth year emergency medicine resident here at Stanford. I went to med school at Penn, born and raised in North Carolina. I think we lost our North Carolina person. But I'm going to be talking about, all right, North Carolina. So this portion is entitled, John is Confident, Jada is Too Assertive, How to Recognize and Minimize Bias in Written Trainee Evaluations, which is something that really affects all of us in this room. So basically what we're going to be doing is defining implicit bias, recognizing how that impacts written evaluations, reviewing current practices to minimize written bias in evaluations for trainees, and then we're going to analyze and edit a written evaluation to practice. So you guys have blue sheets on your table. If you guys would turn them over and then individually kind of look through, and you can underline or circle or figure out which words you think in these sample evaluations might contain implicit bias. If you need a pen, there are some more at the back table. I'm happy to bring some around. So if you could just take 5 minutes for that. So it sounds like you guys are having some good discussion. I just want to bring us back as a group and kind of acknowledge some of the things that you're saying. So I'm going to bring us all back. So maybe each table could give us an example of something that they found. If we could start here. What's an example of something that you guys found that might be implicit bias?
Child care, even.
Okay. Okay. Yeah, and what do you think about that?
I actually can understand the concern that they were late, and that if it's a repetitive thing, that's a problem. Could highlight something that maybe the residency program needs to reach out to that resident to ask if he or she needs extra support. Is there something they can do to help with the child care situation? But the quotation marks seems like it's almost like mocking them.
Okay. What about you guys? What did you think?
So there's no mention of their knowledge, skills, their abilities in medicine.
Yeah.
If that's the only evaluation that they have, they left out the other important part.
Yeah. Okay, great. What about you guys?
I guess similarly, like there was this implicit bias, like the resident is like healer, like motherly, and so like all the actions was like communicate with that.
Okay. What about your table? Anything else you guys want to point out? Here in the back. Yeah. Anything from the second example that you guys want to point out?
We didn't get there, although I will say that, like the sort of coded word urban always irritates me.
And Mike, what about your table? Did you guys have any other ones you wanted to
I
touch on?
circled child care reasons in the home work community. I thought the first one was really funny because as I read it, I was like, well, gosh, that could have been my husband and I. It was funny if it was a male who was getting this, but probably not.
Yeah. So yeah, why does it matter that we have these type of evaluations, right? These are nice things. They're saying nice things about people. But why does it matter that there might be implicit bias in these evaluations? So implicit bias, right, is the attitudes or stereotypes that affect our understanding, actions, decisions in an unconscious manner. So, there's explicit bias where you know that you have bias, and then there's this more subtle, insidious, implicit bias. But in medicine, this is particularly important, right, because starting at the beginning of our medicine journey, in medical school, you get graded, evaluated in clerkships. You have evaluations that then affect your MSPE. That then affects what residency, what fellowship you can go into, and ultimately, right, we're here at an academic emergency medicine conference. In academic medicine, this affects your leadership positions, your tenure, your professorship, your chairmanship, all of those things, right? So all of these things come together and affect your career as a whole. So there's a lot of evidence to support implicit bias in evaluations for trainees and everyone moving forward. So starting in medical school, underrepresented minorities have lower grades in all clerkships when you control for other factors, including test scores and all of those types of things. Underrepresented minorities get lower grades as compared to non-minority students. So MSPE, right, these big evaluation letters that you get as a medical student that are summative. So white students are actually significantly more likely to be described using standout ability words like exceptional, best, intelligent, bright, all of these things, white students are more likely than other students to be described using these particular words. There's also gender bias in the MSP. So female students are more likely to be described using words like compassionate, enthusiastic, sensitive, whereas male students are more likely to be described as quick learners, and that this gap only gets bigger the further you go along in training. So AOA membership, right? Important honor society in medical school. There's huge racial disparities in AOA. So as you can see kind of in this highlighted portion, the only group where the number on the right is bigger than the number on the left is for white students, right? So white students are overrepresented in AOA as compared to their percentage of the medical student body. So white students make up 60% of the medical student body in 2015, almost 72% of AOA. No other group is the number on the right bigger than the number on the left, or even equal. And particularly looking at black students in AOA membership. So this one is just to highlight changes across time. So here we've got 1989, which I was alive, but not that old. And then 2015. So theoretically, there's a lot of big changes socially happening in that time. So you can see in 1989, black students made up just over 5% of the medical student body, and at that time, were less than 1.5% of the students in AOA. Okay, that's a long time ago. What about now? Let's move forward. Oh, still just over 5% of the United States medical student body, and percentage in AOA is half of that what it was in 1989, right? So less than 1% of AOA membership made up by black students. That's a huge disparity. And so I don't know if any of you guys thinking about your medical school experience, right? But I know that I can think of mine, sort of what does your medical school look like, and if you have more diversity, and then who is in the AOA of your medical school, and is that a representative proportionate group? Probably not. This moves forward and continues in residency. So this is a study done about emergency medicine that was actually presented here at SAEM 3 years ago, I think, that was done on gender disparities in milestone achievement for emergency medicine residents. So in education, there's this big movement toward milestones. The idea is that they're very objective, tangible things, that there won't be bias, that you can just look at someone and evaluate on this skill. Do you have this skill or not? What's your level? Should be a very fair, clear thing to do for evaluating. As it turns out, it's problematic. So going into residency, an emergency medicine residency, PGY1, so kind of looking at that blue-green line, men and women are graded on a scale of 1 to 5 at the same level. So the highest percentage, the largest frequency on a scale of 1 to 5 is 2. So you can see that curve for the blue dash and the blue straight line are pretty much the same, right? But you can see while the residents move into their PGY3 year, as they're moving up in training, women, the higher frequency is for 3, whereas men, it moves for 4. So something is happening that by the PGY3 year, men are being evaluated at a full point higher than women on the same competencies, male residents. That represents about a 4 to 6 month difference in training, right? Like that's a big difference in a 3-year program. So what's going on with that? So then there's a qualitative study that was done to sort of look at why maybe those differences on the numeric study were happening. And so they looked at all different feedback from male and female residents, also in emergency medicine, and this time doing more qualitative feedback. So basically the written part that people write in, there's like that box that you make comments. And they found that female residents are getting discordant feedback. So what that means is that their feedback is not the same. So you could get, or I will give a personal example that I have gotten basically on the same rotation. Not confident enough, next line, too confident, right? What do I do with that? I don't know what to do with that. Whereas male residents frequently get consistent feedback. So their feedback will usually say, work on X, and then feedback later down, yep, you should work on X. What do they know? They know they should work on X, right? That's easy to figure out. Whereas if you are getting discordant feedback, it's hard to know what to do with that. Similarly, for women, a lot of feedback tends to be personality focused rather than skill focused. So particularly around issues of autonomy and assertiveness, right? So for me, not confident enough, too confident, those are both personality issues around assertiveness. Whereas male residents frequently get feedback that's not personality focused and tends to be very specific. So work on this specific procedure, or when you're doing this, do this instead, right? There are different types of feedback. So this is just an example. These are real evaluations, right? Anonymous, pulled from this study. So just differences in female and male feedback. So the female feedback on the left, sort of in the more red color, as you can see, argues a lot with the attending, very confident, has a hard time entertaining other possibilities. Next line down, appropriate confidence and autonomy. Those are very different, right? That's discordant feedback. And then next one down, being more assertive, right? So you've got too confident, too argumentative, appropriately confident, not confident enough. What are you going to do with that? How are you going to get better? Whereas for the male resident, this person, you should not defer so much to the attending. Confidently craft a plan. Lay out how you want to execute it. Okay, that's okay. He's capable, but he still needs to work on his clinical decisions are limited. Keep working on expanding that differential. So this person has some constructive feedback, but it's all consistent. You can see it's all within the same theme of working on expanding that differential. Whereas the feedback for the female resident is all over the place, right? You don't know what to do with that. How are you going to get better? And then sort of just another example to highlight sort of how men and women are interpreted differently in the emergency department. So female resident responds negatively to input. She has a negative attitude towards supervision. Male resident, oh, he's argumentative, but he's trying to assert his confidence, right? So female resident is sort of putting some resistance up to supervision. That's viewed very negatively. Male resident putting up some resistance to supervision, it's viewed as a positive. Very different feedback for the same behavior. And so also in emergency medicine, you guys have probably heard of these different adjectives as agentic, which usually are independent, sort of person-focused, versus communal, which tend to be things that are focused on the community, like compassionate, sensitive. And in emergency medicine, a lot of what we value as an ideal resident are things like team leader, independent, decisive, motivated, confident, doesn't complain, all of these things, which are great qualities, but characteristically, these are qualities that our society has associated with men. And so for feedback for men and women, it's much more rare for female residents to be described using these words than male residents, right? Our society is structured such that male residents are much more likely to be described in these terms in what we've decided is the ideal emergency medicine resident. And as I'm sure you know, if you're out of residency, right, this doesn't just end at residency. You can look in medical schools, so female trends, right? Look, so many of them are instructors, but as you move up the ranks, it drops and drops and drops. So women are not advancing to these higher levels of leadership. And similarly, right, for the ethnicity differences, right, you've got white over time, consistently dominating, being a huge percentage, Asian next much, but not much changing, and then all other racial ethnic groups really not making any progress there at the bottom, not being represented in our academic leadership. All right, so that's a lot of information. Lots of studies, a little bit depressing. So just take a mental moment, reset, and write down on a piece of paper 10 people that you trust the most outside your family.
Can I ask a question? Yeah. So for the evaluations that you showed, were those women writing the evaluations for the females? Or do you know, or can you find out, or were they men writing this for female residents?
It's both, and they've looked at differences. So women do not evaluate women in a better light. In fact, frequently women are harsher when evaluating other women, but there's not a difference. That's across, it doesn't change when you look at whether the evaluator is a man or a woman, that those findings are still consistent across that.
So it's not just men evaluating?
Correct. It's not just male attendings. It's men and women. and they subgrouped it, and it's the same for men and women. Yeah. Don't overthink it. Just like 10 people, top people that come to mind, people you trust the most. Rapid fire. If you only get to 5, that's okay. Does no one trust 10 people? Are we a suspicious group? Is that what it is? It's okay. You can have 5. That's okay. That's all right. All right. We're going to move on. Should be quick. Okay. We'll come back to that later. So we've talked about a lot of really sort of depressing data, right, that really is overwhelming, that there's a lot of implicit bias throughout the cycle of medical education and advancement. What can we do about that? Thankfully, there are some practices for how we can sort of work towards challenging this bias. So we think about 3 levels of change, which we've kind of talked about in different sections of this presentation, right? So we think about the individual, and then interpersonal or sort of program level, and then at the institutional level, right? So multiple different levels where you can affect change. So in terms of recognizing your own individual bias, some of you may have taken this test. Harvard has an implicit bias test that you can use for multiple different things. Some of are gender-based, some are ethnicity-based, and I grew up being very conscious of a gender bias. I actually, in kindergarten, my teacher called my mom from school because I was noticing and made a comment that the teacher was calling on boys more than girls. I, of my own initiative, in kindergarten decided to do a little study of when boys and girls were raising hands, the percentage of time the teacher called on boys versus girls. So my mom got called. Because I shared these results, which I felt were negative, with the teacher. And the teacher thought my mom had put me up to this, And my mom was like, I don't know what you're talking about, but that's just who she is, right? So this is something I've been conscious of from a very young age. And I went to a women's college, and so I feel very strongly about working towards overcoming gender bias. I have significant implicit gender bias, right? Such that when I first took this test, I was like, this is ridiculous. Clearly it's wrong. I have no bias. But it's true. We all have, based on where we've grown up, how we've been socialized, no matter how aware you are of it, how much it bothers you, how much you don't want to have it, we all have implicit bias, right? I have significant gender bias on this study. Racial bias, there's a lot of other ones you can do, but this is something that I think if you haven't done can be really eye-opening for things that you think you may be totally aware of or in control of. And the reality is we all just have these biases based on how we've been raised that we don't really have control over. So now I want you to go back to that list of 10 people. And we're going to hand out these green, blue, whatever color sheets these are coming up. And I want you to fill in for all of the people that you listed, name, gender, age, sexual orientation, education level, marital status, and sort of physical ability level. And just kind of go through and see what you found. So we're going to take about 5 minutes for this. All right, and so just notice, looking at your list, if there's any trends that you see. So I'm going to bring us back together here as a group. Is anybody willing to share a trend that they noticed in their list? Yes.
So almost my entire list is women,
Okay.
and almost all of them are women.
Okay. So you, basically, is your list?
Yes.
Okay. Versions of you. Uh-huh. Okay. Versions of you. Anybody else willing to share their list? Yes.
I'm going to say that at this table, one of the thoughts that came up is trust with what and for what purpose. Most of the people on my list are physicians, and I would trust any of them with my life if I was a major trauma victim, but some that are not physicians I would not trust for that purpose.
Sure.
Nor would I trust the physicians necessarily as being protective or with my inner thoughts. So trust for what purpose? When you exclude family, most of the people I trust are family members unto the fourth generation in both directions.
Anybody else find any trends that they wanted to share?
Half of mine were women, half were men.
Okay.
Most were kind of older, mid-50s on up. All were able-bodied, almost all married, predominantly white.
Okay. Anybody else from one of the back tables willing to share anything that they found? No? I'll say that as I came around and was looking over your shoulder at your lists, I did see a theme of many people writing down versions of themselves, which I think is very common, right? People similar age to you, people similar occupation to you, people similar race to you. And I think this is important because as we promote trust and evaluate people, there's an idea of promoting people who are like us, right? We trust people who are like us, who have similar experiences. And that's not unnatural, right? Because you gravitate people to people who are like you, who you can share experiences with. But as we look at who's in these leadership positions, right, do they look like you? And if they don't, are the people that they trust also like them? And how does that affect who we're bringing in, who we're recruiting, who we're promoting, who we're holding up as examples of people that we trust and value? Because many of us do trust people who are like us. So that's just something to think about kind of in terms of who's building our leadership and why we're continually having this problem of not being able to bring diversity up to the higher levels. So it's sort of really a subtle thing that goes on. Even if you're aware of it, right, you may still, in your mind, trust people who are like you. So there's also program-wide, in addition to individual level, there's program-wide strategies. So for people who do evaluations, different strategies. So stereotype replacement. So if you can think of someone in your life who, so coming up with this presentation, for example, one of my colleagues who I came up with it is a very tall black male resident, and he said, you know, think of someone like me who, in college I played tennis and not basketball, right? That's, you know, think of someone who counters a stereotype for you. Or if you know that words like competent are used to describe students or residents of color, try and replace that word with bright or intelligent, or compassionate with, you know, quick learner or something like that. Individuation, so writing specific examples, right, are very helpful rather than sort of vague words. And then increasing opportunities for contact, knowing the person well. You can only write as good of an evaluation as you know the person. So if you know someone more, right, if you've worked with them on more shifts, if you've seen them outside of work, you know, at an EMEG event, if you've gone to a conference with them, you'll be able to have more opportunities for contact, to know them, to give a better evaluation. And so actually a lot of these tips do not come from medicine. We are terrible at this. We do not have good data for this. So most of these strategies actually come from the business world. So also, this is an article from the New York Times, again, focusing on specific skills. So this is sort of, the previous was sort of thinking about written evaluation, but then in giving your feedback in person, right? Focusing on specific skills rather than personality traits. Making sure that your criticisms in your evaluation is really applicable to the job or position that you're talking about, right? Some of the things that we want to give feedback on have nothing to do with the job at hand. You don't need to talk about that, right? If it's not applicable, you don't have to talk about it. And then balancing positive and negative feedback. And then this is from a Harvard Business Review, which is similar, right? Collecting similar data on all of your employees. Having a defined rubric with a defined criteria, having specific prompts, doing consistency checks, right? Over time, are there trends that you see in how people are evaluated? And some of you guys might recognize this box from MedHub, the dreaded evaluation box, right? Where you have to type in your evaluations. But the more space you have, actually, the more space you have to sort of inject bias. So thinking about trying to sort of be consistent across all of the people that you're evaluating. And then thinking about, for your leadership of your residency program, what is the evaluation process for your residents? Is it standardized? Can it become more objective? Who's involved? Do you have a diversity of people on the committee of who's evaluating people, right? Because that makes a big difference in terms of how people are evaluated. And so you can sort of do reviews of your trends. GME as an institutional level would be a great place to start because they have data on everyone. So it would be great if they could also look at all of their data. We could get them to do consistent feedback for everyone and milestones. This is the big thing that is going to have cultural change, and also you have to be transparent about it and accountable, which is hard to get people to do, right? So it really takes an institutional cultural change to do this. So as your tables right now, there's a big piece of paper. So what I'd like you to do is, as a table, rewrite one of the evaluations on the blue piece of paper from earlier. Make it better. Take out what you think is implicit bias, and together come up with an evaluation that you think is a better evaluation. And then you can write it on your big piece of paper, and then we'll share them as a group. You could just take like 10 minutes for this. helps.
He's ready to go right now. He's focused. He cannot multitask. I forget. He's very bad at it.
I'm totally serious. I don't multitask.
Who doesn't? In the office, when we're like working on multiple projects at the same time, we'll be asking him a question, and then he'll be talking about something else. He's like, "Wait, I should be multitasking. 1 second." Like he knows his brain isn't functioning that way.
So I hope you guys have had time to sort of come up with one of the evaluations. In the interest of time, we're going to have to bring it back together. All right, but I love the discussion. Does anybody want to share what they've come up with? Daniel's going to pass around a mic so that we can all hear you. Who wants to share?
Who wants to share?
Thank you. So we were looking at example 1, and we wrote that the resident is intelligent, organized, and gives good care. And we have a caveat to ours, being that we wish that there was more concrete information that we knew about the resident. So if we could have cited more specific knowledge, skill, ability sets of that resident, then it would make for a higher quality evaluation that would be much more objective and much fairer to the applicant.
So needing more information to be able to give that specific feedback. Okay. Anybody else want to share?
So we actually took it and ran and made up information
Great.
to go with it.
I love it.
And I don't, for me, and this is maybe a little bit of my bias, I feel that comparing caring, compassionate healer is a perfectly acceptable thing as long as you include other stuff, because I want residents and students who are caring, compassionate. I know of a resident we graduated who I basically consider a psychopath who has no care and compassion, but we still graduated him. So, you know, I wish we had documentation of that, right? Because that's an issue as well. So we said this resident is a caring, compassionate healer who creates excellent relationships with patients and their families. They are well organized in their notes and patient care plans. Their patient care plans are solid and acceptable / implementable by both other clinicians and patients. Of note, they were late to rounds a few times, which could be seen as a professionalism issue and needs to be addressed.
All right. Anybody else? You guys have built something. Show me what you've built. Be proud of it.
So we also kind of fixed up the first example. We wrote, this resident is a caring, compassionate healer who often spends extra time talking to their patients. For example, and then we put ... for fill in. Presentations are well organized with detailed assessment and plan, and they have excellent interpersonal relationships with patients and other staff members. I did note a few episodes of tardiness on rounds, which has been addressed. So we inferred that if they were already tardy for a couple of times, that was something that residents would have to address, really. Or the faculty.
Okay, good. You guys want to share?
Very excited about the reframe for us for the last part. So the charts are very detailed and complete, and then we wrote down, is currently working on time management.
Right. So right, you can still have constructive feedback, right? But framing it in a way, I think in some ways reading an evaluation, and if it doesn't read as a specific gender or race, right, like that's probably for the best. You want to have specific information that doesn't come across as giving cues to sort of things that people might be biased against. So I think that that's really important, that there's not a separate discourse under what you're saying, right, that you're just giving actual feedback and evaluation, that you're not having a separate discourse about bias around other identities that this person may have. Awesome. So we've kind of looked through these examples and just thinking about, we're going to wrap up here, so just thinking about how you can take these things back to your institution. Hopefully you all got a little postcard with some of the specific strategies on the back. And thinking about things to take back. I think we're just going to go through this part in the interest of time so that we can move on to the next part. But that implicit bias really affects all of us, for better or worse. We don't live in a vacuum. And so this is not something that we can escape no matter how much we want to, right? This is just part of the reality of the world that we live in. But there are strategies to help reduce it, right? Including being aware and having these structured, transparent practices to improve so that we can all improve not only for ourselves, but really to make medicine a better, more diverse and inclusive place. These are some of the citations that I used. So thank you very much for your participation, and then we're going to hand it over to Carmin and Ripple for the next piece.